Hello, I'm Professor Atul Pathak. I'm the head of the National Institute of Cardiology here in Luxembourg. I'm also a board member of the European Society of Hypertension, both a clinical cardiologist and a pharmacologist, and delighted to be here with you to talk about hypertension and cardiovascular risk.
Currently, what are the proven methods to deliver medical and non-medical interventions to treat hypertension and cardiovascular disease?
So currently, the non-medical intervention dedicated for the management of cardiovascular disease are mainly lifestyle modification. And these measures are common for the management of all types of cardiovascular diseases, whether in primary prevention or in secondary prevention. And I think most of us are all aware about them. Stop smoking, try to control your weight, try to exercise a little bit more, reduce the saturated fat, try to eat more vegetables, try to eat more fruits, try to reduce the amount of alcohol, and try to reduce the amount of salt. I would say these are the basics. And on the top of that, you have lifestyle modification, which are more complex, maybe sometimes also less validated with a lower level of evidence, but recent guidelines have emphasized, for example, the role of pollution, the need to reduce the burden of stress at work or at home, or try to reduce, for example, the exposure to microparticles, to noise. So I would say two ways to reduce the burden of cardiovascular diseases, talking about non-medical intervention, lifestyle modification, and new approaches. Now regarding the medical approach, it's usually driven by being exposed to drugs and talking, for example, about hypertension, treating hypertension with a step-by-step approach as defined by recent guidelines, both the US and the European guidelines, where you would start treating patients with the combination of two drugs or of two molecules in a single pill combination, come up with a step-by-step approach where you will increase the exposure to drugs to control blood pressure. And in a more holistic way, controlling blood pressure would be associated with the control of other risk factors. The two most potent risk factors are elevated cholesterol. And there is, again, a step-by-step approach to reduce the burden of dyslipidemia, to be able to reach the target level of LDL cholesterol with the combination, again, of statins, ezetimibe, and new drugs like PCSK9 inhibitors. And the same could be applied for the management of diabetes. Finally, you have to distinguish what we call primary prevention, which has been just described, from secondary prevention, where non-medical and medical management will be dedicated to the cause of event. So if the initial cause of event is a stroke, or if it's an acute myocardial infarction, you will have specific measures, specific tools to address these situations.
Alternative ways to deliver interventions to improve BP control and reduce cardiovascular disease are being considered. What are they?
Yes, there are alternative ways to control cardiovascular risk, and I would say more modern way. The first step is try to build up a team around the patient and try to get the help of all types of healthcare professionals. The classical one, nurses, pharmacists, or physicians, but also anybody involved in the healthcare ecosystem who could help to improve the control of risk factors and help a patient to cope with this disease. So it goes from structures, hospitals which are patient-centered, to systems where you would, for example, enhance the ability of a system to reimburse drugs, from local doctors who will be taking care of patients, but also local nurses, to systems where you are using telehealth or mobile health, so seeing patients through a screen, using the support of a mobile phone to monitor the disease, to follow up the patient, to send him messages to remind him to take his pills or to not forget his appointment. So I would say the first modern way would be to consider the patient at the center of the system, take the opportunity of involving all types of healthcare professionals and improve the quality of care by using new technologies. The second way would be to involve in a broader way, not only healthcare professionals, but anybody who is around the patient. And there have been some very interesting initiatives. For example, the barbershop study showed that when you go in a barbershop, it's a very easy way to be able to detect patients with hypertension. Some initiatives have been also done in churches or even in supermarkets. So expand healthcare environment beyond the classical way. This is, I think, a very important step. Last but not least, education. And we know that there is a cardiovascular tsunami, which is getting ready, which is the burden of cardiovascular disease on younger citizens, and especially children and teenagers. So there is a very important point, which is to try to educate, to improve knowledge, to make patient and young patient aware about the risk. And I think this is the third pillar, which is try to educate, inform, and be able to convince those who are yet not patient, those who are yet not adult, to be ready to cope and to avoid the disease.
What is the latest ESH guidance for antihypertensive combination drug therapies?
The latest ESH guidelines have emphasized the role of combination therapy for the management of hypertension. They are really insisting about the fact that you need to start at the very early beginning by combining two molecules in a single pill. Two molecules which are trying to reduce the burden of the renin-angiotensin system, try to reduce the burden of salt by using thiazides, so diuretics, and try to fight against vasoconstriction by the use of calcium channel blocker. So initially, the step-by-step approach will promote the combination of two molecules out of these three just described in a single pill. If it's not enough, if your patient is not controlled, then you will step up and combine three molecules again in a single pill combination. This is, I would say, the classical step-by-step approach. There are some patients where you would maybe consider starting with this monotherapy. These patients are, for example, the frail patient or patient with elevated blood pressure but high cardiovascular risk. But globally, the mantra is that every hypertensive patient needs to be treated with combination therapy, and combination therapy should be offered in a single pill. If despite combining three molecules in a single pill, you are unable to control your patient, then you are opening the path for new type of drugs, which are under investigation or which have been recently approved by healthcare agencies, or adding a fourth drug, and ideally, again, in a single pill combination, or try to get the help of intervention like renal denervation.
What take-home messages do we have at the end of this interview?
I think there are three very important take-home messages I would like to share with the audience. First, when you are trying to manage patient and when you are trying to prevent cardiovascular disease, you need to take into account that there are, I would say, medical ways to control their burden, the burden of cardiovascular disease, and non-medical ways. And these are usually steps which needs to be associated, lifestyle modification with the involvement of drugs and devices. Second, everybody can be involved in controlling the burden of cardiovascular diseases, the classical ecosystem involving healthcare professionals, but also expanding everything which can be done beyond hospitals and practices to other partners, and try to really support education and improve knowledge about the disease. Finally, I think guidelines are also trying to ease the process and offer the possibility to combine drugs in order not only to improve control of risk factors, but also improve adherence, fight against inertia. And all guidelines are really improving and supporting the need to combine drugs, to use single pill combination therapy in order to better control risk factors and reduce the burden of cardiovascular disease.